We're now going to be talking about bundle branch blocks. After transiting through the AV node and the bundle of His, the electrical impulse travels down the bundle branches. In a healthy heart, the rapid conduction through these bundles will cause the almost simultaneous activation of both the right and the left ventricles. A block, or more accurately a delay in the conduction, travelling through one of these bundles will cause a delay in the activation of the ventricles, either the right ventricle or the left ventricle. In the case of right bundle branch block, the conduction will first proceed down the left bundle, and as normal, it'll activate the septum first. So in V1, we'll see this as a small positive deflection, a small R wave. Conversely, in V6, we'll see a small negative deflection, a small Q wave. Left ventricular activation will then follow, as normal, with a negative deflection in V1, positive in V6. And now we'll come to the right ventricular activation. So the right ventricular activation is significantly delayed as it will occur via cell-to-cell activation, which is slow conduction. Now, rather than on the His-Purkinje highway system, it's going to travel from the left ventricle to the right ventricle slowly, and at this point we'll see a delayed large terminal R wave in V1 representing the depolarization of the right ventricle. In V6 we'll see a large terminal S wave, or a slurred S wave. Now, to sum up, right bundle branch block, we have a QRS greater than 120 milliseconds. We have an RSR pattern in V1 and a wide slurred S wave in V6. Right bundle is a relatively common abnormality and it's not predictive of structural heart disease, unlike left bundle branch block, which is almost always associated with some form of structural heart disease. It can, however, we're talking about right bundle branch block, it can present itself in some cardiomyopathies, in cor pulmonale, and it can be a manifestation after a myocardial infarction as well, usually with other signs. Moving on to left bundle branch block, the septum in this case is not activated normally, so you won't see the initial deflection representing the septal activation. The heart is activated from right to left in this case, and in V1, we'll see a wide negative deflection, while in V6, we'll see a wide positive wave. This pattern can also be seen in the other lateral leads as well, 1 and AVL. So for left bundle branch block, we'll have a QRS greater than 120 milliseconds. We'll have wide negative complexes in the right precordial leads, principally V1, and wide positive complexes in the lateral leads, mainly V6. We'll also have an absence of those septal Q waves in V6 and the lateral leads. So for both right bundle branch block and left bundle branch block, we can have abnormalities of the ST segment and the T waves. In the right bundle branch block, there'll usually be a small amount of ST depression in the right precordials, V1 and V2, and there'll also be T-wave inversions. These are called secondary T-wave abnormalities, meaning that the abnormal repolarization is triggered by abnormal depolarization. You see these changes across various leads in the case of left bundle branch block, and we'll revisit this later on. But the thing to remember is that the changes to the ST segment and the T waves are in the opposite direction to the QRS complexes. So the changes are discordant, they're going in the opposite direction.